So let's go with anatomy first. We have our salivary glands and ducts. There's three glands you need to know about in the oral cavity. There's the parotid gland, which is the largest gland, and I've highlighted it to the right. Your submandibular gland is at the angle of the jaw right here, and your sublingual gland is below the mouth. Now, each of these glands has salivary ducts that can drain the saliva that's produced in the gland and into the oral cavity. And two ducts that you have to know, there's the parotid duct, also known as Stenson's duct, and that's going to be located here, coming off of the parotid gland. And you also have the submandibular duct, also known as Wharton's duct, which would obviously attach from the submandibular gland and into the oral cavity. I want to briefly talk about how salivary glands are innervated because it'll kind of be a nice review for people about how parasympathetic nerves work in general, because it's the exact same mechanism no matter what parasympathetic organ you're dealing with. So how it works for a regular parasympathetic organ is that you have one of the four cranial nerves, either cranial nerve 3, 7, 9, or 10. They start in the brainstem and they send a signal. And that signal will first travel down a very long preganglionic fiber, okay? And at the very end of the preganglionic fiber is a ganglion, which kind of makes sense given the name. And a ganglion is just a collection of nerve cells. And this collection of nerve cells basically allows you to transmit a signal from that long preganglionic fiber to a short postganglionic fiber. And from that short postganglionic fiber, the signal can continue and finally reach the organ that you were hoping for. And in this case, it would be the salivary gland. So let's draw a picture to show this. We have our brainstem. We have our signal sent down a long preganglionic fiber. It synapses once in a ganglion, and then that signal can be transmitted to a postganglionic fiber and finally reach our effector organ. In this case would be the salivary gland, which could regulate secretions, for example. Now, the parotid gland has a little bit different pathway than the other two glands, so I'm just going to show that difference here so you're aware. For the parotid gland, it's actually the glossopharyngeal nerve or cranial nerve 9 that sends the signal, and that signal again will travel down a preganglionic fiber. It'll synapse in a ganglion, which is named the otic ganglion in this case. That otic ganglion will transmit the signal to a short postganglionic fiber and finally reach the parotid gland. For the other two glands, the submandibular and sublingual glands, it'll instead be activated by the facial nerve. And again, that'll travel down a long preganglionic fiber, which is known as the chorda tympani. The facial nerve has quite a few different preganglionic nerves, so the chorda tympani is one to know. That'll synapse in the submandibular ganglion. And then from there, depending on which gland you're going to go to, you have postganglionic fibers coming off of that ganglion into both of the different both of the different salivary glands, submandibular versus sublingual. That's it for anatomy. Physiology has a few different concepts I want you to be aware of. First off, what does saliva actually do for us? So saliva has some benefit in digestion. We have salivary amylases and a few salivary lipases that can start the process of digestion, but I want to make a point that most of our digestion occurs in our stomach, and then most of our enzymes also, especially the lipases, are produced by the pancreas. Another thing we don't think about too often with B12 specifically is that our saliva has something called R binder or haptocorin, which helps us eventually digest B12. And I go into B12 digestion in great detail in the stomach section, I believe. So if you really want to see all of how B12 absorption works, you can check that out. But here I just wanted to point out a few things. So I want to point out that we need R binder or haptocorin to adequately absorb B12. I also want to point out that R binder, like we just mentioned, it's produced in the oral cavity. And this is the most important step here. It's going to help prevent B12 degradation in the stomach. So I'm going to clear the screen and we'll talk about how that works. If we had B12 bound to an animal protein without R binder, what's going to happen is that in the presence of acid, that will dissociate. We'll have B12 hanging out by itself, and the acid will destroy that very quickly. And so we won't get any B12 that's actually absorbed. Now, if we actually have R binder or haptocorin in our oral cavity, what happens is that the hydrogen ions again will dissociate this, but before B12 can get eaten up by these hydrogen ions, it'll be bound to R binder. R binder can safely transport it into the small intestine where B12 will later bind with intrinsic factor and then it can get absorbed in our terminal ileum. So that's how that works. Again, if that's confusing, you can take a look at what I talk about B12 absorption quite a few times later on in the unit too. There's a little bit of antibacterial properties associated with saliva as well. It can secrete IgA, and which is the only antibody that can survive the GI tract. IgA is important for several different organ systems, so I'm just going to talk about it since this is the first time we're encountering it. How it works is that if I sent an antibody, a regular antibody into our GI tract, what happens is that there's luminal proteases that'll come in, it'll chop the antibody in half, and you will have a non-functional antibody. The nice thing about IgA is that it exists as a dimer, which means two of them attached together, and they're attached by a J chain as well as a secretory component. And because of these two features, they can actually go to the GI tract and they can survive there without luminal proteases being able to break them down. One clinical consideration I want you to think about when you think about saliva is that Sjogren's syndrome is a disease without saliva or with decreased saliva output. And for that reason, you can imagine that you'll have an increased risk of dental infections and cavities and things of that nature because you don't have the antibacterial properties that saliva gives to us. Now let's talk quickly about saliva regulation. It's almost entirely parasympathetically regulated, which is kind of why I've already laid the framework of the parasympathetic activation, and we'll talk about that in inhibition in a little bit. It can be activated by sight, smell, or the thought of food. And so activation can occur with muscarinic agonists, as which are pilocarpine and bothanicol are a couple examples, and it could be inhibited by muscarinic receptor antagonists like atropine and scopolamine. So let's go back to our picture. This is our parasympathetic regulation framework that we talked about already. So what exactly happens? What happens when we activate it with like a muscarinic agonist, for example? We'll have our brainstem. It'll send our signal. That signal will reach a ganglion and acetylcholine is released. That acetylcholine will bind to what's called a nicotinic receptor. And that nicotinic receptor, once it's activated, it can send a signal down the postganglionic fiber. At the postganglionic fiber, at the end of that, again, there's a section where acetylcholine is released. But this time, on the effector organ, like the salivary gland, you're going to have a muscarinic receptor, okay? Now, if we have a muscarinic receptor agonist like pilocarpine or bothanicol, what we can do is we can activate that receptor, that yellow receptor, directly with those medications and really stimulate the salivary gland cells to secrete more and more fluid. On the flip side, if we're going to talk about inhibition with things like atropine and scopolamine, we have the same idea where the signal gets transmitted all the way through. But this time, if we have atropine or scopolamine, what they can do is antagonize that receptor. So they will actually block that receptor so that the salivary gland acinar cells do not output as much secretion. So that's why if you give somebody a medication like atropine, they're going to have dry mouth, among other symptoms. Now let's talk about salivary gland fluid modification. Here's a picture of an acinus and a duct. We're going to see this in a few different sections, including the pancreas. So the saliva itself is secreted by these acinar cells, and you can see them right here, lining it. And acinar means resembling a berry or a grape, okay? And it kind of looks like a berry. I could see that. And these fluid secretions that are submitted are going to be initially isotonic to plasma, but later modified in the ducts. And when I talk about, I'll talk about what that actually means in a little bit. I just kind of wanted to give you that as a heads up when we move forward here. So we have our acinus, which is kind of like a berry, or acinus, however you want to say it. I've seen it in both ways, and I might use it interchangeably. And we have our duct. So what happens is saliva is produced in the acinus. it's going to be modified in the ducts, and then it'll finally be released into the mouth. Now, there's three concepts you need to know about how this fluid gets modified during its journey from the acinus to the actual oral cavity. So let's talk first about the electrolytes. So the acinus will release all the electrolytes. It'll release sodium, potassium, chloride, bicarb pretty indiscriminately. And so you'll get all of that into the duct. The duct, on the other hand, has a very preferential reabsorption of sodium and chloride. And I remember this by the mnemonic, ducts eat salt. So that helps me remember, okay, the duct is going to reabsorb the sodium and chloride. On the other hand, potassium and hydrogen have the opposite effect. The ductal cells will actually secrete potassium and bicarb back into the duct, so you'll get a higher concentration of potassium and bicarb. And this is actually physiologically important because the bicarb can protect us from all the acidic foods that we eat. So the acidic foods don't damage our oral cavity, our esophagus, and onward. Let's talk about tonicity, which just means the relative concentration of a given fluid. So the saliva is initially isotonic to plasma. And what that means is that it has the same level of electrolytes to water as our blood does. So we have water coming into the duct and we have electrolytes, and this will be the same concentration as our plasma. The problem is that our ductal cells like to absorb electrolytes, but they aren't very good at reabsorbing water. So you can see our sodium can get reabsorbed, but if we try to reabsorb water, it has a little bit more of a difficult time doing so. And so what'll happen as the concentration moves throughout the ductal cells is that you're going to get a more dilute a dilute salivary duct because the water gets trapped within the duct. And so the saliva becomes hypotonic, which makes a little bit of sense if you think about how viscous blood is. If you've ever cut yourself, you notice how blood is a little bit more viscous. And if you've ever, if you notice your saliva, it's a lot more watered down. And this is why that happens. And now let's talk a little bit about flow rate. So the concentration of water of the saliva at different flow rates varies. And let me explain that because I think I just confused myself by speaking like that. So what's going to happen with tonicity, we'll start with that. At very high flow rates, if your acinar cells are working hard and just throwing everything into the saliva and everything's moving quickly through the duct and into the oral cavity, you don't have time for those electrolyte channels, the ion channels, to actually reabsorb too many of the electrolytes. So, for example, this is what would maybe produced by the acinar cells. And normally we would be able to reabsorb a lot of this stuff. And now we have our hypotonic solution that we talked about earlier. The problem is if the flow rate from the acinus to the oral cavity is moving so fast, we might not have time for all that reabsorption. So some of those electrolytes will stay in the duct, and that'll make the saliva more isotonic to plasma at the higher flow rates. Let's talk about bicarb. Bicarb has this special feature where at high flow rates, your acinar cells are working so hard, they're producing a lot of CO2 as a byproduct, and that CO2 will actually enter the ducts, just diffuse into the ducts, and through carbonic anhydrase, that CO2 can get transitioned into bicarb, which will increase your bicarb levels at high flow rates. And this is, I always remember this bicarb as high carb, where at high flow rates, whether it's the salivary gland ducts or the pancreatic ducts, which I'll talk about later, at high flow rates, you'll always have high bicarb levels, okay? And actually, this is from our pancreas lecture. I'm not gonna go too into detail about this. I just wanted to show you, here's the flow rate here at the bottom. So if I'm over at the right here, we're talking about a high flow rate. And you can see how bicarb, as the flow rate increases, you have an elevation in the actual bicarb concentration as well. So same as the salivary gland duct here, when we look at higher flow rates, you have a higher bicarb concentration. Thanks for watching. I hope you enjoyed the video. Please like, comment, and subscribe for more content.